This week we're covering Chapter 3, and we're going to talk about tolerance, sensitization, and expectation. So the book defines tolerance as decreased effectiveness or potency of a drug over repeated administrations, but I'm adding time into that, and you'll see why in just a second. And the other side of that coin is it can also be defined as the necessity of increasing the dose of a drug to maintain its effectiveness or potency over time or repeated administrations. So it's basically saying the same thing. After some number of administrations, the drug's less effective or less potent, so then you need to take more to get the same effect. This happens in particular with drugs that are used over a long term. And another point here is that some effects you can develop tolerance to some effects quickly, while other effects take a lot longer. The reason why I added time in there is because the book also talks about acute tolerance, where tolerance can develop within a single administration, and that's illustrated in figure 3-1, which is on this slide. It's from your book. The example here is alcohol, and if you look at the same level in the blood, it's level X on the y-axis here. So blood level X during the absorption phase has a lot higher drug effect than it does during the elimination phase. So this is an indication that acute tolerance is developing. And then cross tolerance means that tolerance to one drug transfers to tolerance to another drug. So if you've developed tolerance to morphine, you might already have a relatively high tolerance to heroin or other opioids, other drugs in the same class. So there's several mechanisms of tolerance, different ways that tolerance can develop in your body. The first one we're going to talk about is pharmacokinetic tolerance. This is also called metabolic tolerance, and it's basically increased metabolism of the drug so that less of the drug, fewer drug molecules reach the site of action. We talked about enzyme induction in chapter 1 with alcohol dehydrogenase, and that's a good example of pharmacokinetic tolerance. And in this case, since there's less alcohol or less drug getting to the site of action, all drug effects would be diminished across the board. And then in pharmacodynamic tolerance, the body responds to the drug, the presence of the drug, to mitigate the drug effects. You've heard about homeostasis, where the body keeps all levels of all different kinds of molecules near a set point. And when a drug disrupts that homeostasis, the body has different mechanisms to put into place to restore homeostasis. One example of this is that the book gives is the upregulation or downregulation of neurotransmitters, neurotransmitter receptors. Basically, if there's more receptors available, then a smaller amount would be needed to see an effect. If there's fewer receptors available, a larger amount would be needed to see an effect. You just wouldn't be able to see as much of an effect in some cases. So upregulation means making more of a molecule like that. Downregulation means making fewer of a molecule like that. And that's one example the book gives of pharmacodynamic tolerance. Then functional disturbances, the idea here is just that drug effects must be significant for tolerance to develop. So rats in pain develop tolerance more quickly to an analgesic than rats that are not in pain. The anorexic effects of a drug aren't developed if there's no food available, where anorexia is meaningless if there's no food available anyway. And then last, the book talks about behavioral tolerance. Basically, you can learn to decrease the effect of a drug through operant conditioning or classical conditioning, and we'll discuss more about that a little bit later. We are defining withdrawal as the physiological changes that occur when the use of a drug is stopped or the dosage is decreased. And withdrawal is the state where that happens. So when you're going through withdrawal, you're experiencing those physiological changes. Cross-dependence means that different drugs within the same family of drugs can stop the withdrawal symptoms. So again, using the example of opioids, Maybe if you're in withdrawal, by stopping one opioid, another one could lessen or even get rid of your symptoms. And then dependence and physical dependence and physiological dependence we're using interchangeably here. And basically we're just saying that means that you experience withdrawal symptoms when the drug is stopped. It says nothing about addiction or drug abuse or anything like that. It's just the withdrawal symptoms indicate that there is a dependence. So this slide goes through opponent process theory. The idea here is that drug use comes with at least two different processes. The A process is the euphoria, or the primary effects of the drug, the high, the reason why someone is taking that drug. And then the B process is the body's attempt to restore homeostasis, basically return to normal. So on the left is figure 3-2, and it shows the A process on the top going towards euphoria, the B process on the bottom takes a little bit of time after the drug is administered, but trying to restore homeostasis in the body. In the middle of that figure on the left shows the overall effective state, so you see what happens when you put A and B together. Basically there's a big high at the beginning, the B process brings you down a little bit, and then there's this crash towards as the drug is eliminated from the body. The box 3-1 explains one example of this with basically the body returning to homeostasis after taking anxiolytic, anxiety as a withdrawal symptom of an anxiolytic. And this relates to acute tolerance. Recall from a few slides ago that if your high on the way down is less than it was during the absorption phase, you can be developing tolerance to a drug within a single administration. So then on the right side of this slide is figure 3-3, and this is showing what happens after repeated administrations of a drug. The A process is unchanged, but the B process has become more intense and kicks in faster. This indicates tolerance. There's less effect of the drug. If you look at the overall effective state, the high is much lower. And it also indicates withdrawal because of that longer and stronger B process. The crash is significantly larger. So drug effects can be conditioning. That is, conditioning can alter the effects of drug. And we're going to talk about classical conditioning first here. The book goes through the example of apomorphine with dogs. The unconditioned stimulus is the drug, which the natural response to that drug, the unconditioned response, is salivation, restlessness that leads to vomiting. If a note is sounded right as the effects of the drug start to kick in, then that note can eventually become the conditioned stimulus, and the dog will eventually respond with salivation and vomiting even without the drug being administered. So that's an example where classical conditioning can condition the effects of the drug. And then in addition, the compensatory responses of the body, the way the body gets back to homeostasis, or the B processes that we were talking about with opponent process theory, those are also subject to conditioning. And the book goes through an example where rats were given morphine, and the natural response to morphine is analgesia or pain relief, decreased sensitivity to pain. Then with conditioned, if the rats are conditioned with painful stimuli paired with the morphine injections, the conditioned response can actually be the opposite to the unconditioned response, that is hyperalgesia, or increased pain sensitivity, as compared to analgesia, pain relief. So you see, when the drug effects are conditioned, with the dog's example at the beginning of this slide, the unconditioned response and the conditioned response are both the same. The dog still salivated and vomited. And then in contrast with the rat's example at the bottom of this slide, the unconditioned response and the conditioned response are exactly the opposite of pain relief versus pain increased sensitivity to pain. The idea here is that perhaps sometimes the unconditioned response is not only the analgesia, but also the B processes, the compensatory mechanisms that your body puts in place when the drug is administered, and that's why the conditioned response is actually an increase in pain in this example. So we talked about how compensatory effects, or the B processes, are both contribute to both tolerance and withdrawal. And next we're going to go through how both tolerance and withdrawal can be conditioned specifically. So first, classical conditioning of tolerance. Basically, the example in the book with the rats, the environment became associated with the drug, so that environment became the conditioned stimulus, and then the conditioned response was the compensatory effects that the rat's bodies were giving it to help prepare the rat for the drug, basically to mitigate the drug effects, to decrease the drug effects. And then another example in the book was in box 3-2, explaining heroin overdoses and why tolerance might suddenly be lost if that environment became the conditioned stimulus. And then on the other hand, classical conditioning of withdrawal, basically the same idea where the environment that the drug is normally administered in has become a conditioned stimulus, and then the drug's not given, so the body still it puts out those B processes to prepare the body for the drug, and you experience withdrawal symptoms in that case. And the example that the book came here was an addict on his way home from prison, entering an environment where he had previously gotten heroin frequently before, so his body would start to his body would start to go through those withdrawal symptoms, the compensatory mechanisms that his body was expecting to receive the heroin. So we've talked a lot about classical conditioning of drug effects, compensatory drug effects, and we want to just mention that operant conditioning can also take place with drug tolerance. They give a couple different examples in the book. One is when rats are given amphetamines and they learn with a specific reinforcement schedule. They're only reinforced if they hit the bar in the Skinner box slowly or after a certain amount of time. And the rats can learn to overcome the effects of the amphetamines. They change their behavior to compensate for the effect of the drugs, such that they hit the bar more slowly and they get the reinforcements. Another example given in the book is people with pursuit rotor, one of the motor tests that we talked about before. Basically, the people could train themselves to overcome the effects of alcohol if they were given feedback that was reinforcing them. The feedback was the reinforcement, was training them to overcome the effects of the alcohol. And I think it's worth making a point here. Please do not try to train yourselves to overcome the effects of alcohol. Please do not try to increase your own tolerance. Number one, it's just not a very good idea for your health, and number two, it's just really dangerous, again, for your health. Drinking and driving, the example in box 3-3 about Princess Diana's death, drinking and driving is obviously very dangerous, so please do not try to train yourselves to compensate for the effects of alcohol. The opposite of tolerance, reverse tolerance, is also called sensitization. You can think about it as the opposite of tolerance. So whereas tolerance was repeat administration making the drug effects decreased, making less of an effect of the drugs, sensitization is increasing the drug's effects. If you think about the word sensitize, it's making you more sensitive to the effects of the drug with repeat administration. This is much less common than tolerance, and the book goes through a few different examples of this, and interestingly, it can also be conditioned. Again, different places or situations in the same way that tolerance could be conditioned. The placebo effect is a significant part of the therapeutic value of drugs, and we had talked about before why trials need to be controlled, why drugs that are being developed need to have placebo controls in their research. And this is why it is, because you need to have something to compare your drug to. When a patient has an expectation that a drug's working, it increases the effects that they're expecting. The book mentions that with antidepressants, up to 70%, pain relievers, up to 50% of the effects of drugs is contributed to placebo effects. And again, that's just the expectation that a drug is working makes a person report less pain or report a better mood or whatever the case may be for the specific drug. There's an example of this in the book, Table 3-2, I thought was interesting, where a pain reliever is compared with placebo, and the pain reduction score is highest with the pain reliever, and the placebo gives more than no treatment. But interestingly, if a patient, if it's an open injection, the patient knows that they're receiving a drug or a placebo, both of those generated better pain reduction than with a hidden drug injection. So they did inject the active ingredient, the active drug that they were testing, but the patient didn't know that it was injected. They didn't have that expectation that they would experience pain relief, and the placebo worked better than that hidden drug injection. Another example in the book, let's see, the brain stimulation after administration of Ritalin is dependent on the expectation. And the book goes through, there's probably several mechanisms for how this works, and it's an interesting ongoing area of research. Nobody's really sure why placebo effects work. And then a side note on the nocebo effect is just that placebos can also generate side effects. So again, controls are important. When you see advertisements for drugs that list a bunch of different side effects, nausea, dizziness, sweating, swelling of your limbs, all of a sudden placebo can also generate those side effects again, because you're expecting that treatment might cause those problems. And that's called the nocebo effect. Then the last point in the chapter here is on novel environments, where drugs administered in a new place or in a novel environment have increased effects, and also sensitization can be stronger or more rapid, or with less of a dosage of drug can sensitize more easily. And we had talked about that previously with heroin overdoses in different environments. So again, the context in which a drug can have a big effect on what kind of drug effects, what kind of effects you experience from that drug.